can you see my screen? Anybody?
Wait, yes, we can.
Okay. All right, well, welcome. I'm Dr. Grafton. I don't get to see everybody as much anymore. I don't spend as much time on the 17th floor, but I'm one of the advanced heart failure cardiologists, and also had the opportunity to get critical care training at Henry Ford. So I'm boarded in critical care also. So I've been asked to do a talk on the basics of mechanical circulatory assist devices. And some of the more senior fellows probably seen this presentation before, but I think it's a nice review of the basics of some of the devices that we use. So I have no disclosures. And the objectives of this is to really just review available devices that we use most commonly in the CCU, as well as indications and contraindications for each device, and some of the complications that we see. The three main devices that I'm going to talk about today are the balloon pump, that is A, the Impella B, and C is the TandemHeart. The indications for all of these devices are cardiogenic shock, sometimes for preoperative and postoperative support with bypass or valves or other cardiac surgery, for hemodynamically unstable patients in myocardial infarction, sometimes high-risk coronary interventions. These devices are used during the procedure and removed shortly after the procedure because some hearts have cardiac stunning with the interventions, as a bridge to transplant or LVAD, and then ventricular arrhythmias due to ischemia. Giving patients additional cardiac support can decrease the arrhythmia burden. So cardiogenic shock, yes, we talk about it a lot, but what is the official definition? The official definition is hypotension with a systolic blood pressure less than 90, without any without inotropes, or I guess with inotropes, and then cardiac index less than 1.8 with no inotropes, and then less than or mechanical support or less than 2.2 with support. And then to meet that definition, you also have to have adequate filling pressures. So patients that have low index but are hypovolemic would not meet this definition. So adequate filling pressures, which includes an LV-EDP greater than 18 or RV-EDP greater than 10. And then also one of the most important things is evidence of poor perfusion. So we check lactate commonly. We're always checking for creatinine and urine output, as well as the heart failure handshake, which is putting the hands on the legs and really feeling the warmth of patients' extremities. One of the things that we talk about when we're deciding which support to use is how much support is needed, because each one of these devices is able to provide different amounts of support. So the poor little balloon pump you see on the left side of the screen really only gives 0.5 to 1 liter of additional cardiac output. For our patients that have chronic heart failure and are used to being in very low cardiac index, we still use the balloon pump quite often, and it usually, in many instances, it is able to provide adequate support for those patients with increased perfusion and improvement in the renal function. Patients that have normal cardiac output and then have an myocardial infarction or have something that happens to them that all of a sudden their cardiac index drops drastically, they require much more support generally. And those are the patients that you'll see with Impella CP or the Impella 5.0, TandemHeart, or even ECMO. And then one more point that is important to discuss is just because we can and we have those devices doesn't mean that we always should. So always keeping in mind what the goals are, the overall goals for each patient, and how these devices help you get to the end goal. The most common complications are bleeding, infection, and ischemia meaning limb ischemia because of the large cannulas that are used. So here's here's a patient on the left. This is actually thrombi and ischemia that was kind of sent out by the device to the toes. On the right side, more evidence of ischemia. Sometimes it's because of the large cannulas and we're getting poor perfusion down the whole leg, and that was the case with the patient on the right. This is a picture of an impella, and right by the ruler that you see, there is a tiny clot that was taken off the impella here. And this impella, and we'll talk about it a little bit more, but is essentially taking in blood through the little space that you see in the middle of the screen. And then there's a tiny motor, and then the blood goes to the rest of the aorta. Well, blood clots can happen on both sides of where blood is coming in and blood is going out, causing strokes or limb ischemia. So this is a picture of the balloon pump. So it's placed in the femoral artery up through the aorta. And then there's a little opacity that you can see on the x-ray. And we really want that opacity a couple centimeters above the carina, or right just by where that aorta starts turning down. And that's where that balloon is located. The balloon will inflate during diastole. So what's that is doing is increasing the blood flow through the coronary arteries, because the coronary arteries receive blood during diastole. And then it deflates during systole. So that acts as a significant afterload reducer as that quick deflate, and encourages blood to come out of the left ventricle and through the rest of the body. So this is the waveform that you will see on the console of the balloon pump. And what it's initially showing is it's an A line essentially. So you can see the systolic and diastolic blood pressures. And then the second wave is you see the systolic blood pressure. And then at the dicrotic notch is when the balloon pump will inflate. So then there's an increase, the highest blood pressure is during inflation of that balloon pump, and then it deflates quickly for a significant afterload in that low blood pressure. Contraindications to the balloon pump are aortic regurgitation, because you can imagine when that balloon is inflating, if it's inflating against a valve that doesn't work, you're essentially just sending blood backwards into the heart. Aortic dissection, because of the balloon is going up and down within the aorta. Aortic stents for the same reason. And severe PVD, and that's really because you're putting sheaths in the pulmonary artery and increases the chance of limb ischemia. Relative contraindications to also think about, though: abdominal aortic aneurysm, again, the balloon pump is going through the aorta. Septicemia, and that's really because those patients have really low afterload as it is, and the balloon pump just doesn't tend to help patients that are septic shock. If you have bleeding, that's a problem. At Henry Ford, everyone on a balloon pump is also on a heparin drip. Some centers do not use heparin when the balloon pump is 1-to-1. So if you have to stop the heparin, that is okay with a balloon pump if it's on 1-to-1. We always want to restart the anticoagulation as soon as possible. And when you're weaning off, then we drop the balloon pump to 1-to-2 or 1-to-3, so it's not inflating with every heartbeat. Those are the times that having a therapeutic heparin is really important. And then again, peripheral vascular disease came up. The advantages are it's widely available. It uses a 7 to 8 French sheath, which is much smaller than some of the other devices that we'll talk about. It's easy to implant. and it's also easy to remove and to manipulate. The disadvantage are that it really is only giving you, here's 0.3 to 0.5, some places say 0.5 to 1 liters per minute increase in cardiac output. It depends on a regular cardiac cycle. Some patients in atrial fibrillation or irregular heartbeats are on balloon pump, but you don't get the same benefits from the balloon pump. You can get embolization because of a clot on the balloon that's later embolizes. There's a tiny risk of aortic dissection. If the reason that it's important that the balloon pump is sitting up near the aortic arch is because if it gets too low, there's a thought that it can cause renal ischemia. I don't see this common, and might be because we are very diligent about checking the morning x-rays every day, but that is a possibility, and stroke for the same reason of the systemic embolization. Any questions about the balloon pump? Okay. We will move on to the Impella, which if you spend any time in the CCU, you know that we use often. I will say that we are probably one of the biggest users of this across the country even. So something that seems so normal in our CCU is not used as often in other hospitals. So it is something definitely that we have a lot more experience with than other places, but it comes in different sizes. And the Impella 2.5 means that it can give you 2.5 additional liters of flow in cardiac output. The Impella CP gives you about 3.5. Impella 5.0 is 5. And then the one on the right side is really a right-sided Impella to use for RV failure. The 5.0 is most commonly, and it's made to be implanted in the operating room because of the increased size of the catheter, the sheath that's needed to place that Impella. We do use it sometimes though in the transcaval Impella. So these are some pictures of what the Impella looks like in the heart. There's the pigtail that goes into the left ventricle across the aortic valve. There's the intake where the blood is taken out of the left ventricle, and the output, which is pushes the blood through the on the other side of the aortic valve and to the aorta to the rest of the body. And then within that housing, there's this tiny axial pump that's used to power that blood to come out of the left ventricle to the rest of the body. Contraindications for the Impella include a mural thrombus. So you can imagine if you're sucking blood out of the left ventricle and there's clot in that left ventricle, you will essentially clot your Impella, or you will cause stroke from the blood, from the clots being sent to the rest of the body or to the brain. Mechanical aortic valve you cannot have because this crosses the aortic valve. Moderate to severe aortic stenosis, and that's more because this large catheter is crossing the aortic valve. And then peripheral arterial disease, again, you can cause some limb ischemia if you have severe PAD. The advantages of it, is that you can get increased cardiac output. It does not require stable cardiac rhythm. It will just flow depending on what speed you put it at. You will get that amount of flow. And then at our institution, it's very widely accessible. One of the other disadvantages though, so here are the disadvantages. So you can see it's a larger French sheath that's used opposed to the 7/8 French sheath. Now we're getting into the 12 to 14 French sheath, which increases the risk of vascular complications. These devices can be quite a nuisance because of the movement of the catheter, which can also get caught up in the either mitral valve apparatus or also crossing the aortic valve and not being able to work like it should. Again, systemic embolization, stroke, infection. And one of the hardest things that I battle, or that we battle, is the hemolysis that's associated with it, because the pump is so small. If you get turbulent flow or any blood clots in the little motor, the hemolysis is just horrible, and then it will cause anemia requiring blood transfusions. But even worse, these patients get AKI because of the hemolysis. A TandemHeart we don't use as much, and the reason, it is a great device. What it is there is a large catheter that's placed up through the femoral vein into the right atrium, and then crosses the septum into the left atrium, that's where it's drawing the blood from. So it's drawing blood from the left atrium. It comes out of the body, and the main pump is on the outside of the body, and then blood is put back into the femoral artery. These patients that are on this have a low cardiac output, so that allows the blood to flow up closer to the heart and to the arms and the brain, even though the catheter's in the femoral artery, as well as to the lower extremities and organs. It's more stable and has been approved to provide support for 14 days. As if you've been in the CCU, you'll notice that we use the Impella is actually only approved for, I think, 72 hours, but patients are on that for much longer than that. But this is a more durable device. And you can get good flow and increase cardiac output and decrease wedge because you're drawing that blood right from the left atrium. So this is another picture of the cannula across the aortic or the atrial septum, where it draws blood from the left atrium, comes out of the body, and then the outflow is in the femoral artery. It can be kind of a pseudo ECMO setup because this allows you to, because blood's getting pulled out of the body, it allows you to set up an oxygenator. So you can have these patients placed on an oxygenator to oxygenate blood if needed. Contraindications are severe aortic insufficiency, because blood will start just pooling in the left ventricle, which can cause distension and worsening the heart failure when you're trying to get improvement. Aortic dissection, peripheral vascular disease, ventricular septal defect, and patients have to be anticoagulated for both this device as well as the Impella. You can get a good cardiac output with this device, and it is approved to provide support for 14 days. This device moves a lot less, but the problem is if this device moves, we've had a patient or two that somehow the cannula was dislodged from across the intra-atrial septum, and there's no really, you cannot adjust the cannulas in the CCU, and they require to go back to the cath lab and can decompensate quite quickly. This device is not as available because it does require the increased ability, the increased knowledge and experience to cross the catheter across the intra-atrial septum, and requires that transseptal puncture that can be complicated by bleeding into the pericardium. It's hard to implant this, or you can implant this during CPR, and sometimes that's what we do for ECMO. It has a larger cannula, so now we're up to 17 French femoral artery cannula. Stroke is the same, and then lower extremity ischemia is more, again, because of the increase in the cannula size. I'm not going to talk about ECMO very much, but it is in our toolbox for mechanical support. So this is specifically VA ECMO. can provide up to 6 liters of flow, so really complete cardiac support. As you know, it's able to support oxygenation and perfusion. The cannulas can be placed in the cath lab, operating room, or even bedside if needed. And it can provide support for biventricular failure. Complications include bleeding, infection, extremity ischemia, stroke, and hemolysis. And as you know, these patients are required to be on anticoagulation, therapeutic anticoagulation, and if you're having patients that are like profusely bleeding out, you can hold anticoagulation for short periods of time, but the clock's always ticking to restart. Another complication, or something that you hear a lot about, it's tested a lot, is north-south syndrome. And really what that is just like the TandemHeart, well, the blood's taken out of the right side of the heart, right atrium, usually out to the ECMO circuit where the oxygenator is, as well as the motor of the system. The blood's placed back into the femoral artery, and because of the low cardiac output, the blood continues to flow up, just like the tandem, flow up into the upper extremities, the head and neck. But if the lungs are not working well, and you're not getting good oxygenated blood in the left ventricle, and the heart is starting to pump a little bit better, so it's pumping against that ECMO flow that's coming up, you can get hypoxia, especially in the right upper extremity, as well as the right carotid artery. So these ECMO patients via ECMO, we always try to put in a right radial art line if possible, so that and the pulse ox goes on that right hand. So we're monitoring the oxygenation, trying to prevent north-south syndrome or Harlequin syndrome. And then, of course, we don't want to forget about the right heart that can cause significant problems in patients with cardiogenic shock. I'll show you just a couple. There are a couple different algorithms, and really most of the algorithms include really supporting the left ventricle as best you can, and then continuing to monitor the hemodynamics in the cath lab. Here are a few different equations that are used to reassess what the right side is doing. So right atrial pressure greater than 15, greater than 18 is considered or is consistent with RV failure. We talk frequently about the ratio from the right atrial to the wedge pressure, and if that's greater than 2/3, then that is consistent with RV failure. There's the PAPI that's taking into consideration the pulse pressure of the right ventricle over the right atrial pressure. And then there's other things. RV stroke work index, PVR is something that is commonly used for more chronic chronic RV failure and pulmonary hypertension, as you know. And then PA compliance, which to be honest, I haven't really used. So you have some support in the left side, whether it's the balloon pump or an Impella, and you're continuing to watch their hemodynamics in the cath lab, and it looks like there's still problems with RV failure, so meaning we're not getting enough blood from the right side of the heart to the left side of the heart to be able to fill that device to increase the cardiac output. And so then we think about what can we do for the right side of the heart. The easiest device to probably place is the Impella-RP, which is the right side, and it's kind of the way it works is reverse of the left side Impella, so it's drawing blood here from the inferior vena cava, and then it is pushing blood into the pulmonary arteries here where the outflow is. And that unloads that RV. And typically once the RV is unloaded, it is able to improve its function. But when it's so distended and full, it just can't keep up. There's also the right-sided tandem, which uses a kind of a Protek duo type catheter. So blood it's again placed through the right atrium, right ventricle into the pulmonary artery. Blood is drawn out through the right atrium, in through the tandem device, can be oxygenated, and then placed back into the pulmonary artery. This was a nice paper. It's a little bit older now, 2016, but if you have additional questions on when patients are evaluated for additional or percutaneous support. But it had a nice chart in it that is able to say all in one chart, more details of what we've kind of talked about. So how much support can you get with each device? How does it do it? The sheath size required, and then how it affects the hemodynamics of the heart. So when we're talking about afterload reduction, the balloon pump is great afterload reducer. Same with the Impella. The TandemHeart and the ECMO, they can increase your cardiac output even more, but because blood is flowing in through the femoral artery and backwards against the heart, those are actually increasing the afterload. And I'm not going to go through each of them, but I do think that it is worth looking closer at what each device does if you have specific interest. And then this is the algorithm, and it's a lot of messy stuff, and you can look at it further, but it's really remembering to support the LV as much as you can, and really not forgetting about the right ventricle also. Just a few slides now on durable LVADs, and really I'm just going, so here's our initial LVAD. There was actually a VE that I think was approved in 1998, but this was the XVE that we initially used. And when it was compared in 2001 in the rematch trial, when it was compared to optimal medical therapy, when it was compared to optimal medical therapy, it did show improved survival at 24 months, but definitely started to drop off about after 1 year. You can see that the XVE is just huge. It was in the abdominal cavity and was really difficult in smaller patients and women. This is compared to the Heartmate 2, which was our next generation LVAD, which was much smaller and became an, I'll show you. This is the axial flow of the Heartmate 2. So again, this is the x-ray of what this looks like on the outside, and this is the axial flow pump. As you can see, there's a cannula in the left ventricle. It comes through the pump. The outflow graft is attached to the aorta. You have essentially an electrical cord that's coming from the pump through the stomach, outside the skin of the stomach, and then to the controller and attached to the batteries. The batteries nowadays last about 8 to 12 hours. And when they're not on batteries at night, patients are attached to the wall outlet for electricity. This was our next LVAD, so getting much smaller. There's centrifugal pump here. Again, the main pump is in the left ventricle, drawing blood out. with the outflow graft attached to the aorta. Heartmate 3 is our best pump that we have to date. Same type of design, to centrifugal pump into the left ventricle with the outflow graft to the aorta, with the drive line coming outside the body right here, and then the controller to the batteries. So our this was survival on the pulsatile flow was the XVE. So when we went from XVE to Heartmate 2, significant improvement in survival at 24 months and further. And now our best pump, the Heartmate 3, is showing survival that's consistent with even transplant at 2 years. And we're still on the 5-year. You know, VADs, they continue to get better. We get better at probably choosing the right patients. There's still a lot of complications. The most common complications are GI bleeding and stroke, infection because of the drive line. So they're not without their complications, but really do give patients their life back, allow them to live at home. Other than swimming, getting in small boats, or showering, they really can do everything they want to do.
Excuse me, how does the device create an artificial pulse?
Yeah, so within this pump is that there's like this kind of disc that's magnetically levitated, and that is the pump. And what it does is about 5 times a cycle, it will slow down its speed, and then it increases the speed above the baseline. And so that's kind of the pulse. But you wouldn't really be able to, you wouldn't be able to tell a lot by like examining a patient, but it's essentially changing in the speeds.
The reason I asked that is that years ago, I was looking at pulse oximetry and its ability to be accurate in this circumstance. And it has some difficulties, as you can imagine, because it's not a pulse. It's not a pulseless oximeter. It's a pulse oximeter.
Yeah.
So the question is, does this really dilate the arterial flow to the point where a sensitive pulse oximeter could pick up an accurate signal? And I'm not sure the answer to that, but kind of a question.
So I will say, well, I don't think so based on the pulse from the pump, but this pump is able to tolerate a little bit higher blood pressure more. And we find that the patients on Heartmate 3 tend to be a little bit more pulsatile just from their cardiac, their like native cardiac function and the pump together. So these patients, many of these patients are able to get automatic cuff pressure.
You're fading out. I can't hear you.
The Heartmate 3 patients, can you hear me?
Yes.
Okay. The Heartmate 3 patients tend to have more pulse, and it's not necessarily because of this artificial pulse, but just these pumps, you can have somewhat higher blood pressures. They still work well. Before, we were having to drop patients' blood pressures as low as possible to allow the pump to work well. So these patients actually tend to have more of their native pulse, and we can even sometimes get blood pressures with automatic cuffs, which on some of the older VADs we could not.
Thank you.
Any other questions? All right, well, I think that's the end of my talk. Thank you.
Thank you.